Good evening, everybody. Let me start the presentation today. I'm Dr. Suel, medicine resident from India, from Bangalore. The topic of my presentation was the role of clinical examination in the management of patients with respiratory disease in the background of evidence-based clinical care. So coming to introduction, the physical examination and history taking are the backbone of diagnosis in traditional teaching of medicine. So in this commerce-driven modern era of medicine, they are losing their importance due to rapid advances in technology, and clinicians are depending more and more on investigations for making a diagnosis. So, however, with rapid escalation in the cost of medical care and large number of patients still being treated in resource-depleted setting, the clinical examination is the most effective tool in the management of the patients. So the brief summary of what I am going to tell today is this article is an attempt to give a template for predicting the probability, establishing treatment, and testing thresholds for common respiratory symptoms based on the evidence-based medical medicine methods. So this gives an advantage of evidence-based clinical decision making. So what is the use of this? So how is evidence-based clinical decision different from it? The traditional teaching in clinical medicine was focused on history and clinical examination for a list of differential diagnosis. In the evidence-based approach, the diagnostic process starts much earlier by estimating the pretest probability. So the utilization of these resources of evidence-based clinical medicine, the review of literature studies for valid, accurate, and precise is an exhaustive process which requires diligence and the ability to understand errors in the background of statistics. So the differential diagnosis will have a leading hypothesis not to misdiagnose. So there is a focus on establishing a treatment threshold and test thresholds for effective and early management of patient rather than arriving at an absolute diagnosis based on gold standard techniques. So to make use of evidence-based validated scales and algorithms in choosing the test and designing treatments, it's very helpful. So management decisions are based on post-test probability of disease, which is arrived by either Bayes theorem or easily available normograms. So coming to materials and methods, the basic statistical parameters are explained here. So the technique which we use here is a likelihood ratio of symptoms and physical signs and probability based on prevalence, and narrowing the differential diagnosis in a common respiratory disease is advocated. This article gives the prevalence of causes for common respiratory symptoms, the positive and negative likelihood ratio for the historical features and clinical signs, and capacity available in the evidence-based resources till date. So one of the scenario we can take here is chronic cough and breathlessness. The chronic cough breathlessness COPD is one scenario where the disease is almost always seen in older patients with more than 70 years a pack history of smoking. The patient can either be the outpatient or an emergency department can present with an acute exacerbation case of COPD. So diagnosis of obstructive airway disease is clinically possible only in 50% of cases and only when it is severe. Better clinical examination. So the gold standard for diagnosis of obstructive airway disease is spirometry. And the spirometry criteria for diagnosis of chronic bronchitis, we already know FP1 upon FVC, it's like more than less than 70%. And also the increased volume of lung due to rate wrapping. So the clinical parameters with highest predictive value is very important. Just by the history, for example, like history of smoking more than 70 pack years, past history of COPD, and in examination, the air breath sounds a diminished in intensity. Using the likelihood ratio of 2 out of 3 is present, the likelihood ratio is high, 27.5. With the help of this clinical history and examination, we can narrow down the diagnosis unnecessarily need of any investigations. So for moving further towards the likelihood ratio, we have got positive likelihood ratio and negative likelihood ratio. Positive likelihood ratio, the physical findings of this likelihood ratio includes like early inspiratic repetitions, breath sound score 9 or less, absent cardiac dullness, left atrial border. Whereas in case of 5 to 10 points are given if there is a subspecified cardiac impulse or Hoover sign positive. Coming to negative likelihood ratio, it's to rule out. To rule out, in case of point 1, point 2 value of ratio, breath out score 16 or more, forced expiratory time. Coming to the pleural effusion, one of the scenario we can take is pleural effusion. Pleural effusion scenario where the pleural effusion is seen in medical ICU patients, 8.4%, whereas the paranemic effusion to 22, 30%, and heart failure 87%. The gold standard which we are using here for using X-ray. The coming to the use of evidence-based template is symptoms of respiratory disease is helpful in the diagnosis of all common disease. So, like for example, we can take the previously known post-nasal dip syndrome is now called upper airway cough syndrome and is characterized by abundant secretions for the upper respiratory tract that drip into the oropharyngeal and tracheobronchial tree, causing cough. So, it is the most common cause of chronic cough and diagnosed with simple history of mucus strip in the back of the throat. And similarly, the second commonest cause is gastroesophageal reflux and is diagnosed by simple history of heartburn most of the time, unnecessary to go for any other high-fi investigations. And the causes of chronic cough and breathlessness is more diverse. The main issue is differentiating COPD and bronchial asthma. So diagnosis COPD requires a spirometry in most of the cases, though the history and patient profile helps in evaluating the disease. Whereas diagnosis of bronchial asthma is clinical, though spirometry may be required for assessing severity and treatment. Uh, Coming to the discussion, so the differentiation of COPD is important, and use evidence support helps in differentiation of two most common causes of cough and breathlessness. So differentiation is important because the marked differences in the treatment, decision, progression, and the outcomes. So the diagnosis of COPD is almost always requires spirometry, interpreting the pattern of patient symptoms, smoking, age, comorbidity status. So the crossing of treatment threshold with clinical parameters, tension pneumothorax helps in early and life saving measures. The use of validated scale in the management of patient with pulmonary embolism. The use of validated scale in the management of patients with pulmonary embolism, for example, well scoring system is much more better important in narrowing down the probability rather than going for imaging or gold standard techniques. And also the look out for alarming symptoms in case of bronchogenic carcinoma like hemoptysis, weight loss, and breathlessness at the onset. So the use of evidence-based predictors in the help in narrowing down the subjects who require the chest X-ray in patients with pneumonia and pleural effusion. So the use of evidence-based template also helps in diagnosing the streptococcal pharyngitis, sinusitis, which may help in reduction in the patient with a sore throat, sinusitis. So these are the references for the study. Dan Meyer, Scott, David, Emil. And to conclude, I want to just tell that the existing literature on the evidence-based medicine is utilized to select the test objectively and cost-effectively to arrive at a reasonable diagnosis. And the focus is on early treatment, minimal delay, and the optimal investigation, supported by the available evidence in the literature. Hence, there is an increased confidence level in treating physician in the diagnosis and management of a patient as it is supported by a solid evidence. Thank you.